Welcome, everyone, and thanks for chatting in. We are going to get started. I think we still have people joining. So welcome. I'm Marie Abraham. I'm the Vice President for Programming and Publications at the Institute for Patient and Family-Centered Care. And today I'm joined by my wonderful colleague, Deborah Dawkin, who is IPFCC's Senior Specialist for Patient and Family Partnerships. And providing technical support, expert technical support, I will say, is our colleague, Matt Da Silva, who, as you can see the pinwheel, maybe in your window, that's Matt is behind that pinwheel. We're really excited to see how many of you registered and are joining us today. It's obviously a topic of significant importance. So yes, and for people who are just joining now, feel free to chat in your name and your organization and where you are located. So next slide. We just want to acknowledge our PFCC Connect sponsors. Thank you to Emory Healthcare, Providence Healthcare, and the University Health for your continued support that allows us to keep our PFCC Connect learning community open and helps us out with these sessions. Next slide. So just a reminder to everyone, we want to make sure that we keep this conversation interactive as well as informative. So we're going to be sharing a few slides just to set the context and provide some information to get the conversation started, but then we'll dive really deep into the discussion. But we just want to remind everybody of our group agreements. So please be present as possible. When we move into discussion, it would be great if you could come on video. Participate actively. We encourage you to be curious and ask questions, but also share your experiences, perspectives, and any challenges you're facing. I think this topic has been quite a challenge for people. You can either chat in your questions or ideas or raise your hand to be called on. Let's make sure to share space. Allow others to contribute to the conversation. This is a very large group, where I'm looking at 171 right now, which is pretty large. So we want to hear from as many of you as possible. Embrace a learning and growth mindset. All of you bring expertise, and we have a lot to learn from each other. So we're really looking forward to this. And finally, we hope you enjoy the discussion and have fun. If you have any technical issues, you can chat with Matt Da Silva directly. So I think with that, Deborah, I'm going to hand it over to you.
Thanks, Marie. Next slide, please. Although this is an informal conversation in which you will share your experience and expertise with one another, we did want to provide just a little background information about our topic today, measuring the impact of patient and family advisory councils. On this slide, this refers to an article that was published about a study, a systematic review investigating whether PFACs could be linked to improvements in quality, safety, or satisfaction. And the authors concluded a couple of things. The published evidence was limited and primarily case-based, and that little progress had been made in the past 15 years since the publication of a previous systematic review on the topic. So the authors concluded that rigorous evaluation of PFAC programs is needed to support their expansion. Next slide, please. So Maria and I wanted to just list a couple of things about why we think it's important to measure the impact of PFACs. First, it highlights their importance and builds the case for their continuation and expansion. It also demonstrates to PFAC members and other PFAs that their involvement does make a difference. And we do know that this kind of measurement is a best practice employed by exemplary PFACs. Next slide, please. Some of you may remember that IPFCC has conducted 2 studies of PFACs, one in 2018 looking at New York State hospitals, and one in 2021 looking at PFACs in children's hospitals in the US. Both looked at the prevalence and functioning of PFACs, including reporting and evaluation. And what you can see here from these side-by-side stats from those studies, evaluation is not done by all PFACs. In fact, you see in the Children's Hospital study, it's only about half. And that measurement primarily focuses on numbers of PFAs, numbers of hours they contribute, numbers of activities. These 2 studies are both available on IPFCC's website, and we'll actually have citations for that at the end. Next slide, please. So we really are kind of putting forward that what we think we can do better is focus more on clinical and care delivery measures in the future, because the focus now is more on process measures. Next slide, please. And when we're talking about process measures or descriptive measures, they are the same things that I mentioned before, where we count the numbers of advisors and meetings and staff in departments that they partner with. Next slide, please. But less frequently, we measure the impact or the clinical and care delivery outcomes, because in many ways that is more difficult. It requires identifying clear goals and outcomes, and also having a process and tools to do the measurement. We do want to very quickly share one example from Kamansky Children's Hospital and a simulation-based discharge program that they did. The program was co-designed by the Family Advisory Council, and Family Advisory Council members were part of the program, and they were able to study and measure some of the outcomes of that program. Courtney Nataraj, a longtime member of Kamansky's Family Advisory Council, will share very briefly about their evaluation of that program. Courtney, are you there?
Yes, I am. Thank you. Thank you for having me. Yes, so our program that we co-created back in 2016, and it was, like I said, co-designed between the hospital staff and the Family Advisory Council. What we do is we provide education to families who are medically complex and have technology going home. And during that education, we have the FAC member there along with the medical staff to provide the education. And the important part about having the family member there is that they are able to give really important insight that only a family member who's had a technology dependent child would know. It's one thing for the doctors and nurses to be teaching the families and to teach the proper way to do things, but there's just certain tricks that only a parent knows who's caring for their child 24/7. So the way that we were able to take some measurements of this program and how well we were doing when we were educating the families is that we gave them a survey before we did any education with them. And we asked them, many questions of, did they know the size of their trach? Did they know what to look for in emergency? Did they know how to look for infections? How comfortable were they feeling? We really wanted to focus on their comfort to provide this care at home. So, as I said, the survey was before the education, and then we provide a 3-hour education with the families. And we also then do a checklist with them as they're doing the skills on a high fidelity mannequin, because we don't want them practicing on their child. We want them to practice the same way that the doctors and nurses learn how to care for our children also. And so when they go through that, we do a checklist and we score them of how they're doing on the care that they're providing to the mannequin. But it's really not scoring the parent, it's scoring the education that we're giving them so that we learn how to improve the education that we're giving them. And then after the education is done, the families then took the exact same survey with the exact same questions so that we could gauge how more comfortable that they were. And so we found that most of them became so much more confident in what that they were doing, because this is a 3-hour training and we let them keep going and practicing the same skills over and over again until they're 100% confident. And so it was just really a wonderful way for these families to practice, and then for us to see the impact of what we're doing and the wonderful support of the hospital to support us in this program. And this program came about because myself, I had a child that came home with technology and things went horribly wrong. And when I was able to share my story with the hospital and the medical staff and what I thought could improve that for other families, they were 100% behind us. And we're very happy with the outcomes that we've had. We've educated over 150 families now. So thank you.
Thanks so much, Courtney. And we share this as one example of a PFAC designed and implemented program that was able to look at the impact and the clinical and educational outcomes of that program. Next slide, please. We have lots of, or a handful of questions to guide the discussion today. But we do know from past informal conversations that the discussion not only will be robust and rich, but that it might have started already with people using the chat. So I want to weigh in quickly with my colleague, Marie Abraham. And Marie, do we have anything that's already trending as questions and discussion in the chat?
Yes, people were asking for the study, so I added a link. It didn't work, so I added another link that links to the article. It is open access, so you can all get it. And so try that link if you want it. It's the Sharma article that Deborah was speaking about earlier. There's a question for Courtney, and the question for you is, what's your role in the organization and what departments supported this?
Yes, so I am a PFA, patient family advisor. I am the past chair of the Kamansky Children's Hospital PFAC, and the different parts that support this, I would say it's everything from GI, pulmonology. We have complex care that's involved. We have palliative care that's involved, child life, social work, the nursing staff, medical directors, quality and safety directors. I would say in our first meeting that we had, there was 40 people that showed up to the meeting because everyone was so excited to be a part of the program. And obviously we have medical students involved too. I mean, it was really everyone from every department's involved.
Thanks, Courtney. There's a question okay, so well, let me handle one question at a time. The is PFAC relevant for primary healthcare services? And, I should have said this earlier in the opening. We are thinking about both PFACs as well as patient and family advisors in general, who might serve on committees or work groups or different groups like that. So yes, we've worked in primary healthcare services with in different ways, and I'm thinking of one organization that worked with their advisors to improve the I'm spacing on the name here, the after visit summary. So it was more patient friendly, and then they did track those outcomes from that. So I think Courtney has chatted in that that her hospital, her organization, does provide a stipend. And there's another question: is there protected time for admin staff capacity to support your PFAC? Deborah, do you want to talk about that question? Because it's so important to have a dedicated and designated time for somebody to be working on that.
Thanks, Marie. I'm sorry we don't have slides for that specifically. But those that fact is something that was part of our 2 PFAC studies, and certainly highlighted as what an exemplary PFAC would have, that it really contributes to the effectiveness of the PFAC. And I encourage you to look at those 2 studies. And as I said, they will be included in the citations we share at the end. But I'm wondering now, Marie, if there aren't any other questions or issues raised in the chat, do we want to open it up now? And I think we'd be curious to hear how other organizations who are on this discussion, how have you measured the impact of your PFACs and PFAs and the work they do?
Yeah, and we do have some questions about getting leadership support and commitment. And I saw that, let me scoot back, Jennifer has responded to that. And I don't know, Jennifer, if you can come on and talk about getting that buy-in and commitment from the highest levels of administration.
Sure. I'm just trying to, there, my camera's on. Thank you very much. Yes, I'm in the PFAC for the Champlain region cancer care PFAC, and it's based out of Ottawa. And we have found over the past 10 years or so, our PFAC has developed significantly. And the reason that it has developed so quickly and so fulsomely has been the tremendous buy-in by the highest levels of administration. We're talking the CEO of cancer care and of the hospital in general. And we found that our voice is heard. We make sure that we are working along with the priorities of the hospital and of the region itself within cancer care. And we have found that the oncologists, the administrators have all been extremely receptive and happy to have our input, because essentially what it does is it takes some of the responsibility from them to provide perspectives on an issue they may know of very well from a medical or administrative perspective, but not from actually experiencing the treatments, et cetera. So I think that is really the first thing that you need, is to have support from the organization.
Jennifer, thank you for that. And that also is something that IPFCC found in its two studies of PFACs. And again, if you look at those two studies, you will see that as one of the findings. Emily, I see you have your hand raised. Did you have evaluation tools or methods that you've used that you wanted to share?
Well, I work at Kaiser Permanente in the Northwest region, and we have PFACs or other ways of listening to the patient voice all over the country. And the main way that it gets measured is outcomes that happen that you get from things like Press-Ganey. So they're farther down the road, and it's hard to connect them back to the patient voice where it came in. And one of the things that I'm pretty sure everybody's aware of how strapped medicine is these days in terms of not just dollars, but time that employees have to spend on things. And we spend time and money on organizing PFACs and having staff members who participate actively in them and so forth. But asking to measure the outcome of those in a way that has some rigor to it, that's a whole nother world of time and money. And I'm wondering how you do that. Do we ask Press-Ganey to start demanding it, or state laws? It's such a, to me, it's a quandary for well-meaning health organizations.
Thank you for that honesty, Emily. I think that's probably why so many people registered, because this topic is one that many people are grappling with. I do want to, is Darcel Jackson from Children's National on? Because I know you've done some tracking of your PFAC, and would you be willing to share what you've done?
And we've got several people in the chat who I'd like to call on as
Okay.
well.
I
One thing to keep in mind, because I know we're talking about measurement, and when I work with healthcare systems or quality improvement collaboratives, we always, like, if you're working with patient and family advisors or patient family advisory councils on a specific topic, then look at that topic and see what outcomes that you will be measuring. I kind of think about it as in a quality improvement process. So if you're working on discharge and transition to home, then what's a good data point to be looking at instead of waiting for your Press-Ganey results, your HCAHPS results. Could you look at readmission rates? Could you look at number of ED visits from those people? So it's taking your topic of a project, linking it to the most relevant outcomes, and then using those. Your organization would have those data points. And I know there's a hand up too. So is Darcel not on the call?
I
Okay,
didn't hear her. So
we have let's go to Lelise. Lelise, do you want to unmute?
Yes. Hi. Hey, Marie.
Hey,
everybody. And yes, I think I come from the same venue, from quality improvement and research. And the reason why I was so interested in this call is because it says how to measure our impact. And I personally have been working in quality improvement and family patient and family centered care for 15 years. And I think that after the pandemic, we are all really scratching our heads as to what has been really our impact into process measures and outcome measures, and how we are, you know, we have an army of people here, 2,033 people just in this call. And we know that we have thousands of families working with healthcare bodies in different levels, and a lot of us do it for free. So, you know, I'm reading at the paper that you guys discussed at the beginning, and it says there are 5 studies in the conclusion, and then it says, based on these studies, patient advisors tend to contribute. So what are the tangible ways of really measuring our impact? I think that it remains a question mark, right? I can tell you that from the many times that I have been involved in discussing our impact, the big pushback that we get from clinicians is, well, how do you know that X, Y, and Z change in culture or in process or in outcome is really reflective of the work that patients and families are doing? And so if anybody has any other tool, I hear about the tools, but if anybody has any more tangible ways of saying, hey, this specifically, I think that what we are grappling here is the fact that a lot of hospitals or entities fight to recognize the influence of patients and families, right? And attribute the authorship of the changes that we do make. So anyhow, if anybody has any concrete tools to say, hey, this happened when we implemented it, I would very welcome. Thank you.
Thanks, Lilies. Jennifer, your hand is up, and I know you spoke before, but do you have something quick to say? And then we're gonna.
Yeah, sure. I didn't want to jump to the head of the line. I just think that as far as measurements go, what we're doing as patients and family is basically we're moving the cultural and societal standards forward. So we're bringing the healthcare system, which is a very traditional system, forward with us. So what we need to do first is to convince them and show them that we can be value added. And I think that the primary way to do that is to be collaborative in nature and not combative. That approach is key. We tend to collect statistics of successive programs and what has happened during the course of the year for all the multiple different PFAC involvement in different initiatives across the region. That helps. It's all qualitative measurements, and you know, that's okay. I think that's just fine. I actually prefer it to doing measurements where you are mentioning the number of people or the number of meetings, because to me those are who cares, is my own view. But I think that if we can move forward and we can see a change in the societal values as reflected in the healthcare system, then we know that we're making some progress. I'll stop there.
Thank you. And James, your hand was up next.
Yeah, hi, good morning. Sorry, I have a head cold, but I also have an eye infection, so I'll stay off video. But first of all, it's the first time I joined these. I followed your, maybe this community and organization for a long time, and I'm the co-chair, actually my public member co-chair colleague, Pam Dawson, and I are from the interior BC in Canada. We follow your work closely, and we borrowed a lot of that, and we both co-chair a person and family centered care steering committee, which is why we were interested in this topic. As it turns out, I've been involved in this work. I'm a program evaluator. I've been that my whole career. So a couple quick thoughts and maybe a question. I'm terribly interested to move to do more program evaluation of how our organization's adoption of a framework that we'll call it person and family centered care, the 4 standard sort of principles, which you're all familiar with, how well we're doing. I've been functioning in a different role, more to sort of champion and move person family centered care along. I think most of us here all buy into that. As an evaluator, some others may be on the call or planners here, at the crux is what do we theorize each in our different organizations is the contributing factor. 2 speakers ago, or 3, I think nailed it, is really in my job, and not everybody wants this or welcome to it, we do need some evidence to address most of these questions. But I think breaking it down, as I'm listening to the conversation, what question I have for the group is, even if it's not published, do we have what are some people call fancy word counterfactual? Do we have examples in organizations where initiatives that we know for sure, or organizations where they have chosen not to put in PFACs, have laggard or been laggards, or suffered in some ways in the uptake generally of person and family centered care related initiatives? I like the example that was published. Again, the question is, did you need the PFAC for that initiative, or would a general patient engagement have got you there? These are the questions our senior executive and board will want, not just me, but others to help answer. So I'm really curious to know, if we only have it in gray literature, do we have examples of counterfactuals where things have gone bad or worse, over the past 5, 10, 15 years without PFACs?
Deborah, do you want to speak to that?
I think, and again, I hate to sound like a broken record, but going back to, because they are the ones that we have in the field now, the 2 PFAC studies, and the one in New York State, we were able to look at the results from our PFAC study, and a ranking that was done of high performing or higher performing PFACs than others. And we were able, with our research team, to look at those in light of HCAP scores. And there was a relationship. We're very careful about, we don't want to use strong correlation terminology, but there was a relationship that organizations that had higher performing PFACs had better HCAP scores. And the data is pretty well laid out there's an extensive report for that New York State study. So I encourage you to look at that part of it.
Deborah, do you want to mention that we also looked at some of the CMS indicators there, and there was an association?
Yes. So it was with those indicators as well. We were not able to do that, unfortunately, with the PFAC study of children's hospitals, because children's hospitals, that same data is not collected. So that was something that was, a disappointment, because it would have been really great to add to that base. Anyway, so that's one response to what you were just asking, James. I see we have some more hands raised. Courtney, I'm going to skip over you just for a minute and go on to Penny, because you have not said anything yet.
Thank you. I'm a former member of the PFAC at Dana-Farber Cancer Institute in Boston, and I'm now currently on the PFAC for the ED at Mass General Hospital. And so it's interesting talking to you about measurements. And at both hospitals, I feel we've got a great measurement. And it's basically at the beginning of the year, the CEO of each of the organizations comes and talks about what their goals are. And then it's up to us to look at those goals and say, okay, what kind of innovative projects can we do? And they can be all over the place. Some can be for patient experience by opening up a charge card so that people, can get get movies or whatever it is. And then there are other things that help the clinicians in terms of their diagnosis and what have you, like preparing a GI binder for a cancer patient. And then at the end of the year, we give a score. We talk about what our deliverables are going to be through the year. We work through them on a project basis. And at the end of the year, they come back and we give them a report about all the different things that we've done. And, if they have any issues and what have you, like we didn't really focus on this, or we could really use help here, they talk to us. So it's not a bunch of different numbers. It's really looking at what the goals of the organization, the institute are, and how can we help to impact them.
Mhm. And Penny, because you're in Massachusetts, where there is legislation around having PFACs in every single hospital in Massachusetts, and do you still report out to Healthcare for All at the end of the year on
Yeah,
outcomes?
that's just changed. And I'm not sure if Healthcare for All, did they decide to pass it over to the Betsy Lehman
Okay.
organization on patient and safety, and I'm on their PFAC reorganization, so to speak. So there are a bunch of us from different hospitals, but yes, we do give annual reports, and we've been giving them to Healthcare for All. They're circulated, but now it'll be through the guys at Betsy Lehman.
Thank you. Deborah, we still have some hands up too. Oh, you're on mute.
Diana, do you want to share what your organization is doing or pose a question?
Sure, thank you. I'm Diana Lemaire. I am the past chair of the London Regional Cancer Program, PFAC, and I am currently, I sit on the PFAC for the Ontario Institute for Cancer Research. And there were just a couple of things I wanted to comment on. The first was the concern about using counts and frequencies as descriptive indicators and their value or non-value. I think it's important to understand that if you don't have processes, then you don't have outcomes. And when we look at process indicators, we are asking the question, if we are going to make an impact or achieve an outcome, how are we going to do that? And then how are we going to know that we did what we said we were going to do? So if we said we're going to recruit 200 patient partners over the next fiscal year, then that count is an important indicator in terms of did we achieve that outcome. Now, if you're talking about impacts in terms of, and here's my concern, a vague, general, we're going to make the hospital a better world type of indicator, you will never, in my view, be able to measure that. I think it is very important to look at what outcome are you trying to achieve? Is it a realistic outcome? And what is the context around it? So if your project is one on a medicine ward and you want to, I don't know, I'm making this up, but you want to implement a rounding program that includes a patient partner, that's very specific, and that allows you to, I think, manage measuring outcome. If your outcome is patient-centered care is going to be #1 for everyone that works in the hospital, a little more difficult to measure. So I think it's important as PFACs to understand where it is you want to make a difference. Because I think that where you can be the most powerful as a PFAC is looking at what are the specific problems that a cancer program or cancer researchers, in my case, or a specific type of care like children's, and to look at what are the problems and how can we as a PFAC help people get the job done in a fashion that's patient-centered. and we will model that behavior for others. So I guess what I'm saying is I think we have to be careful about how grandiose we are in terms of looking at what is our impact and what are our outcomes.
Thanks for sharing that, Diana. And I hope we didn't in the introduction suggest grandiose. It was one of the reasons we wanted to share the example from Kamansky, which was a specific program co-designed by the Family Advisory Council with the involvement of council members. In the interest of time, I'm going to call on Delinda, and then I promise Courtney and James, who have been so patient with your hands raised, that I will come back to you. But Delinda, do you want to share something with your colleagues?
Sure, thank you. This has been very helpful to hear. I think I'm from Fox Chase Cancer Center in Philadelphia, Pennsylvania, and we've had a PFAC for about 13 years. From day one, when we first put forth our proposal, we've reported directly to the Quality and Safety Subcommittee of the board. And so on an annual basis, we actually report to the board on progress from the prior year. And that annual report is based on the activities of the year, which we pull from our dashboard, which is quarterly, includes things such as what projects we've been working on, the hours of our advisors, topics they've addressed, and then from our annual retreat, what projects we agreed to work on and how successful we were with partnering with the institution on those projects. So that helps. That's our way of monitoring our progress, and it's been working for us. Thanks.
Okay, thank you for sharing that. Courtney, I'm coming back to you.
Thank you. I'll be really quick. But since everyone's talking about HCAHPS scores and how, and measuring it that way, I'm sure that a lot of you are aware that narratives is something that has been a hot topic with HCAHPS and adding narratives in there. So I think another way that we can measure what we're doing is not only a study, such as our program that was published in a study, but reading what the feedback is from the patients and families that have done it. I mean, I'll read some just 2 quotes of 2 families that wrote back from us from the simulation discharge program. And it was, "You were so positive and confident during the simulation. It made a difference on how I felt about it and that we could do this also. And, if you were walking beside me on this journey, I don't know how we'd be doing it." Now, I think for upper management to hear something like that, that's pretty impactful. But I think it's just as impactful as the numbers.
You're on mute, Deborah.
Sorry about that. Thanks for sharing that, Courtney, and bringing it back to actual voices of family members. James, did you have something to add on to what you shared with us before?
Yeah, just really quickly, I don't want to take up extra time. Maybe just 2 comments. I really want to re-echo what Penny, Diana, and Delinda have all shared, which is, at least my interpretation, I'll paraphrase, is, each PFAC or our steering committee, based on our terms of reference and where we report, and it's really important for us to be clear about our objectives. And our steering committee has had some strategic planning to do that. I see comments about how do we get resources, how do we get support. The part I want to insert here that will also be super familiar, or kind of like I'm doing a head smack on the face, duh. But as we report to seniors, as a program evaluator, part of the reason I got into wanting to do this is because any evaluation we do on any program, for a long time, I've wanted our team to make sure we have patients, public members that are co-creating the evaluation. So the little sort of thing I want to shoehorn in here is whatever evaluation or monitoring you do, and Pam, who's listening, I'm sure this is my commitment, is that it must be done in a collaborative fashion that involves the participation, and dare I say, ideally, It's not done to, it's not just done with or for, but it's done as patients and public members. And by the way, I use public members because many of the folks who have patient experiences, when they feel elevated to PFAC type of status, they actually want to move into a different kind of role as public member beyond just a more unique and narrow patient experience. So I don't mean any disrespect by that. So my plug would be co-creation of the actual evaluation itself. Don't let the senior executives or management, well-meaning as they are, dictate that framework. So that'll be my little plug for that too. That doesn't erase all the need for resources and folks like me to hopefully weigh in. Thanks, Deborah. Great facilitation today.
And James, thank you. That was really an important sort of coming full circle to remind us of that part of co-creation. I'm going to turn it over to Marie for a moment now, because we do have one final question we'd like people to think about and raise their hands or comment in the chat.
Deborah, I'm fine with holding on that slide for just a moment, because we have Melissa and Anne Marie.
Oh,
and I
sorry.
see that we also have Pat who's here and would love to share about what they do with their PFAC.
Sorry, I missed those two hands.
That's okay.
Melissa?
Hi, thank you so much. This has been so great to listen to everyone share. Currently, we have a PFAC group. They're very brand new and just kind of getting started to help us in the development of a care coordination program that we have. One of the things I'm wondering, especially when it comes to co-creation, which is truly, I know the ultimate goal, but it's like that starting point of supporting our members and being able to also co-create. I don't know, maybe this isn't the time to chat more about it, but putting it out there in the sense of supporting our members to be able to fully participate, especially on that knowledge base of how we're doing things, but also wanting all of their experiences and expertise along with it. Some of the things that I run up against is, I don't know what maybe the right terminology is, but just even the development. I provided an assessment that was given to us because of the grant that we are working with and asking for input and ways to change it, but it sometimes feels like that may not be where they're at this moment.
Thanks, Melissa.
And let's see, Anne Marie, and then Marie, you said that Pat has.
Yes, Pat chatted in that she'd love it if we have a minute.
Yeah, Anne Marie.
Hi, thank you. I am a patient. I am not in any kind of hospital affiliation whatsoever. And I am so excited about this PFAC concept. I want the whole entire country to take over and adopt this. I live in Minnesota, and I was a patient who had some horrible experiences. I addressed it to the hospital, and they denied that they needed to make any changes. I feel like this is giving us a voice to help make administration understand where there are failures or shortcomings within hospital systems. And despite my proactive, trying to change things in the hospital, it did not work. And I have a particular disease where hospital care, medical care is very shortcoming. It's very outdated information. And there were situations where I was put into near-death experiences, giving me outdated drugs that I should not use. And I am not alone. I belong to many forums related to this disease. And I think PFACs are a way to bring attention to the administration. I want to make hospitals better. And I think this is a phenomenal way to start and make better changes. And ditto what James Coyle said. Thank you so much.
And Anne Marie, we're I mean, very sorry to hear about your experience, but we encourage you to even start on the IPFCC website, where there's a special section about PFACs. It will give you a little bit of the history, but more of current practice, because PFACs are quite prevalent now. And your experience, especially in Minnesota, where we could put you in touch with other hospitals that do have PFACs and support their PFACs, et cetera. So, Pat, do you want to share what you all are doing in terms of?
Sure. I mean, I'm so proud of our hospital and of our council. We've been in existence for 17 years, going to celebrate our 17th anniversary this month, November. And we're fortunate because when we created our PFAC, we knew families needed to be at the table when things were talked about or decided or goals were made. But we also we knew we needed the partnership of our administration. So our CEO for our hospital is a member of our council and participates in our council meetings and listens to report outs and gives his feedback as well. So he's very transparent with what's going on at our hospital day to day, and also includes our PFAC in conversations about, the strategic plan for the hospital and organizational goals. But we use two of our sessions on November and December. Well, we meet one time a month in the evening for an hour and a half. And then during November, December, and January, we brainstorm our goals for the next year. So we already know the goals of the hospital. We're already aware as customers that come where there could be areas of improvement. And we all come from a place where we love the hospital and want them to succeed for all of the families. So we come up with 5 or 6 goals, talk it over with our leadership team, come back to work, and we form work groups. Then each work group takes on a goal and they have a separate meeting. They bring their updates back to the larger council and we progress the goals with everyone's feedback. So in 17 years, we've accomplished all of our goals, and our families brainstorm the goals. They're family driven. So this past year, we're a high reliability organization. Our CEO talks about that and our progress as an organization with that. But the families felt like, wow, you have to invite the families along with that journey. So they developed safety infographics for all of our inpatient, outpatient, and long-term care units. Flyers are given out to families, and it's empowering them and inviting them on this HRO journey for safety, and that they need to speak up with things that they could do every day using a safety acronym. And, we're very proud of that. And our entire hospital system used that for World Patient Safety Day, and our council created that. But another goal separate from that, our CEO talked about employee engagement and our scores, and the staff loves the clinicians that care for them, and they love their providers. And they were so sad to hear that some of the scores were lower. They helped to create a toolbox for recognition for the staff from a family perspective, for leaders and other staff members to use. But the family is embedded in it because they know their clinicians. They know how to appreciate them. So I'm just giving you some examples. Like, they're all very meaningful to both our families and both our staff. And we accomplish our goals and see the impact. So I just thought I'd share that. We're still all very passionate 17 years later, and we feel valued at our hospital because of the work that we do.
Thank you, Pat. I'm glad you were able to join us. And now I am going to turn it over to Marie, because we have some closing comments, etc. These sessions are never long enough, sadly.
Yeah. Can you skip to 2 slides, Matt? Yeah. So we don't have time to really get into this. However, if you are so inclined, if you want to think about, did you have an aha moment today? I did. I recognize that one of the things that I think is really important is if you want to make the case to your leadership, if you want to get that commitment, then you've got to be measuring the outcomes. You got to be looking at that and sharing that with them so they understand the benefits and the value of having patient and family advisors as well as PFACs in their organization. But if you want to, good, we've got some people putting in their aha moments. So Matt, if you can go to the next slide, please. So here are the links to, or here are the resources that were discussed today, and we really encourage you to take a look at them for more information. Some of these were included in the chat, but all of these have great information. And the last bullet here is the link to our web section just on patient and family advisory programs. So if there are other tools, there was a lot in the chat, and we'll be sharing those. We'll be sharing the chat after the session is over at some point. We're probably on Monday. You can look for that in the PFCC Connect. But if you do, we can upload them to the PFCC Connect as well. Next slide, please. So we really value your feedback. Talk about outcomes. We want to see some of your feedback and your input. And we do ask that you complete the survey because we use those results to give us ideas to improve our conversations as well as think about future topics. So if you can complete the survey, you can either do it by going to the link, and I should put that link in, or yeah, I should put that link in. I will as soon as I stop talking. Or you can use the QR code that's listed here. And next slide, please. So as I said, the recording and the slides in the chat will be posted on PFCC Connect site. It does take us a little bit of time, but we will get that done very quickly. I would look for it early next week. If you have other resources that were not linked in the chat and you want to send us some tools or materials, please feel free to do so. And you can send those directly to me. My email is right there. And also consider continuing this discussion in PFCC. Oh, okay. So Matt, can you go back to the previous slide? Just to have the QR code up. Thank you. Yes, we can continue this discussion in the learning community, PFCC Connect. So please feel free to do that. We like to make that site engaging and interesting. So please do that. Okay, we can leave it on here, Matt, for the next 30 seconds, just so people can get a time. And thank you all so much for participating today. I know we didn't get to every single comment and question and idea in the chat, but if we think, or if you think you want to continue this conversation and get into more detail about evaluation, let us know. But thank you very much, and have a wonderful
Thank you,
day.
everyone. These are always wonderful, and we always regret that there is an endless time. But please complete the evaluation and give us ideas for the future.